You're listening to ExPhysCast, your one-stop shop for anything and everything exercise, science, and physiology. Now here are your hosts, Jamie and Luke Pelton.
Hello everyone and welcome back to ExPhysCast. I am your co-host, Jamie Pelton, and I'm sitting here with my husband, Luke Pelton.
Hello.
How are you doing today, Luke?
I am doing great. It's a rainy Sunday when we're recording this. Hopefully it's a bit clear weather whenever this airs.
Yeah, I think it's supposed to get to 80 degrees this week. So
oh my goodness.
Hopefully. Anyway, today we're going to be talking about your brain on exercise. So really exciting stuff. We have an awesome guest speaker coming to speak with us at the end of the episode. Luke, anything to add?
We're going to follow a similar format to what we did last week. We're going to introduce some basic concepts in our Breakdown the Basics segment. One thing that we want to emphasize that I don't think we really talked about last week is that this is, for the most part, what's called a segment show. So we follow a kind of segment by segment format. Our plan is occasionally to have some kind of like special, unique episodes. So if you guys have any ideas of things that you want to hear, maybe like a feature guest, somebody pretty popular in the field, we do like a full interview episode with that person or a full discussion episode. That could be cool. Any ideas you our listeners have, we're more than happy, as always, to hear. You can leave those as comments on the YouTube link here, or obviously on our Instagram, or whenever we get on Apple Podcasts.
I think we need one more after this one, and
right,
then we'll be there.
We gotta have 3 in the chamber to get on. I don't know if it's Apple and Spotify, or if we have to pick and choose.
I'm not sure.
Because I know that there's a certain popular podcast that rhymes with Mo Logan experience. I don't want to throw any names out there. I guess transferred to Spotify from Apple Podcasts or from YouTube recently and lost a ton of listenership.
Okay.
Because of that switch. I love Spotify. I'm not being paid to say this. I generally like Spotify. We'll see. We will let you know, obviously, via Instagram. Yes.
When we get to it.
Or burn that bridge whenever we get to it. We'll see.
Just as a reminder, we are doing a t-shirt order. We had a lot of interest in t-shirts. So if you haven't already done so, please let one of us know if you are interested in a t-shirt. We have white and black t-shirts to start with. So just let us know. And without further ado, we are going to get right into today's episode with the Breakdown the Basics section. Luke, would you like to start us off here?
Yes, that'd be great. So I'm going to introduce probably the largest overall thing we're going to talk about today, which is brain-derived neurotrophic factor, or BDNF for short. So our guest, Greg Spicer, he's a PhD candidate. He's going to speak a lot about his research on BDNF later on. Both the studies we looked at really focused on this. It is probably one of the largest links between exercise and the brain in terms of health and memory. So it is a protein. A lot of these small compounds we talk about are protein derivatives. It's a member of the neurotrophin family of growth factors. So anytime we see neuro, obviously we're thinking
brain.
Right, brain neurons, exactly.
Central nervous system.
Yes. And this suffix, so trophin, so the troph suffix generally means what? Growth, anything like that. Hypertrophy, neurotrophin, all right, neurotrophic. So it's just going to be growth and development whenever we see that. So BDNF itself plays a really integral role in what we call neuronal plasticity, which is the ability of the neurons to develop when faced with stimuli like any kind of learning experience that we're exposed to, or any chemicals that are released on the brain, and especially involved with nerve growth through adolescent development and adulthood, kind of helps form that neuronal circuitry in the brain and help with our cognitive processing. So obviously hugely important to memory, thinking, etc. It promotes synaptic consolidation, which is actually when we kind of have a first pass of something that occurs in our life and we're about to form a memory. We can think of it almost as like a short-term storage, but then that has to be almost downloaded to the hard drive and codified in the brain, and that's that synaptic consolidation. So it's taking that memory and then forming it into a long-term memory. I think Jamie's going to talk about that later on in one of the studies that she looked at as well.
Not one of the studies, but one of the basic sections.
Got it, okay.
Just briefly.
Cool. So we'll touch on that later as well. BDNF also increases neurogenesis, so the growth, development of new neurons. It kind of helps increase cells' chance of survival and proliferation as opposed to just dying off. And again, that's that apoptosis that we spoke about last episode.
Right. And for our listeners, genesis is always going to be talking about new growth of something.
Right, exactly. It also leads to, again, those changes in synaptic connection, which is going to help with memory storage, and that's related to that synaptic consolidation. So BDNF is the mediator between brain function and the stimulus of exercise. So its gene expression is modulated by exercise. In particular, probably the most famous aerobic endurance gene of the PPAR alpha 1, which is hugely responsive to aerobic exercise and metabolic imbalance, so energy expenditure during such exercise. We see a positive relation between exercise exposure and BDNF, which is associated with, like you said, those increases in neuronal plasticity and cognitive ratios. And the studies we're going to talk about later will dive into that connection heavily. What happens when BDNF is downregulated? Well, we see severe damage on the executive circuitry in the brain and memory processing centers. This can lead to things like cognitive decline and memory loss. In terms of genetics as well, we can see a polymorphism, a single nucleotide polymorphism. That's basically, if we think about the long strand of DNA that codes for these genes, one of those little bases, we should have a genetics episode to talk about all of this because this is very complex. I'm not going to dive into it now. We basically have one base that's switched out and it's something that it shouldn't be. And what happens is this codes for an incorrect amino acid when we're forming the BDNF protein. So we have a valine amino acid switched out with a methionine amino acid. This is the most common gene mutation that we see in BDNF, and this actually might confer a disadvantage in cognitive performance, especially in episodic memory. So remembering the order of things in which they have happened. Aging also sees a reduction in neurotrophic signaling. And I want to stress that whenever we hear about aging leads to this, we're talking about aging in a vacuum. So if we are making health conscious decisions, exercising, dieting correctly, age really can just be a number. Not everybody who's 65 years old has the same physiology, all right? The more active and the more kind of physiology, health conscious lifestyles are leading, the better off we're going to be on the inside. So to that end, this aging as a reduction in BDNF might not be a mechanistic cause, but a symptom of other things going on. Aging might be a good topic for another episode as well.
Absolutely.
In the future. I actually just recently gave a talk at Springfield College on the physiology of aging. It was pretty well received. So there's definitely a plethora of information out there, especially if we have some of our older listeners.
Yeah.
Might be interested in that.
Absolutely.
Thinking our parents.
Sorry, guys.
They're definitely the younger side of
Absolutely.
the 60s.
Absolutely.
Where were we? Okay, right, BDNF. So we find high concentrations of BDNF in brain regions such as the hippocampus, the amygdala, the cerebellum, and the cerebral cortex. It's highest in the hippocampal neurons. And we're going to talk about the hippocampus later on as well. It is also found in the liver, heart, and the lungs, though in much smaller quantities. I think Greg is going to talk about this as well, but it's produced by muscle fiber RNA, RNA being one of the single side strands of the greater DNA chain. And it can actually rescue motoneurons, so the neurons in motor regions, muscle cells, from apoptosis, that's cell death, which is pretty cool. It's formed originally as pro-BDNF, so kind of a precursor to the actual mature protein. It's stored in the dendrites and the axons of neurons, which is the main part of the cell body. If you think about the diagram, and the little tiny spindly guys coming off, those are the dendrites. Those form connections with other neurons. It's cleaved, so kind of cut in half to produce the final mature BDNF protein. From there, it can do all the jobs it needs to.
There are a lot of jobs.
It is a lot of jobs. To understand the neurons a little bit, I'm going to turn it over to Jamie. She's going to talk about those for a few minutes.
Yeah, so neurons are the main component of our nervous tissue. They're also known as nerve cells, and we have billions of them in our brains, which is just a huge amount of number to think about.
Yeah.
Neurons are an electrically excitable cell that have the ability to communicate with other cells through specialized connections. These connections are called synapses. We have a few different types of neurons. So we've got sensory neurons, motor neurons, as Luke was just kind of touching on a little bit, and then interneurons. So our sensory neurons respond to stimuli. So think touch, sound, light, all of those things, kind of like our senses, essentially. And then we've got our motor neurons. So these receive signals from the brain and the spinal cord to control muscle contractions, like Luke had just mentioned. And then we have our interneurons, which, as you can imagine, connect neurons to other neurons within the same region of the brain or spinal cord. And then a few of these interneurons can form a group of connected neurons that is also known as the neural circuit. And I'm not going to go into all of the different pathways and neuronal pathways and all that, because it's much too complicated for a breakdown the basics section. But just so you can get an idea of what Luke was talking about with that image in your brain of the little dendrites and axons and everything. The typical neuron consists of a cell body, or a soma, and then we have our dendrites, which have like these little finger-like projections coming off of them. We have a single axon, and then most neurons will receive signals via the dendrites and soma and send signals down the axon. So I'm going to go right into our hippocampus and memory centers section, as Luke had touched on the hippocampus a little bit earlier. So our hippocampus is a major part of the brain. We have one on each side, so we have a right and left hippocampus. It's important for consolidation of information from short-term memory to long-term memory, and in spatial memory, which enables our ability to navigate. So as I was reading that, I was thinking, who does the hippocampus think it is, kind of dictating what makes it to our long-term memory. And I now always think of the movie Inside Out. I don't know if anybody's gotten a chance to watch that.
A new core memory.
But every time we talk about memory or different parts of the brain, I immediately think of, a new core memory.
It really did a great job.
It did.
At bringing the brain processes to life and keeping it like fairly accurate, but in 3D animation.
Right. I mean, it must have, because we watched it, over a year ago, and we still bring it up all of the time.
Yeah.
So yeah, I highly recommend the movie if you haven't seen it yet. Let's get back to where I was now. So in diseases such as Alzheimer's or dementia, the hippocampus is one of the first regions to suffer damage, as short-term memory loss and disorientation are typically the first symptoms in those types of diseases. Different neuronal cell types are organized in neat layers in the hippocampus, which is why the hippocampus serves as a model for studying neurophysiology. So lots of neurophysiologists and researchers will look at the hippocampus specifically when trying to find some information about the brain. And then I came across a fun fact as I was doing my research a little bit, that the name hippocampus is broken down into the Greek words horse and sea monster, which is pretty silly, pretty funny, and was named that back in the 1500s because of how closely the hippocampus resembles a seahorse. So I'm hoping that at this point everybody is now Googling a hippocampus, because one of the first images that will pop up is the human hippocampus compared to a seahorse.
Nice.
And it's like the shape is like almost identical.
I have two fun facts to interject here.
Oh yeah.
First of all, did you know that the male seahorse brings the babies into the world?
Yes.
Yeah.
Yeah.
I always found that was pretty cool. Secondly, this is a hippo-related fact. So hippopotamus comes from the Greek words for water horse. So it's a horse in the water.
All right. So back to what we're here to talk about today.
Back to the brain.
I'm going to switch it over to Luke.
Speaking of memory.
I'm going to switch it over to Luke, and he's going to tell us a little bit about IGF-1.
All right. So IGF-1 stands for insulin-like growth factor 1. So it's another one of those growth factors, like we mentioned. It's a bit of a neurotrophic growth factor. We're going to talk about its unique role in memory in a few minutes. It's a small polypeptide hormone. So we have different kinds of hormones in the body. We can have steroid hormones, which are formed from cholesterol rings as a basic unit. But we also have polypeptide hormones, or just simply peptide hormones, which are formed from amino acids like proteins. So it's about 67 to 70 amino acids long, which is small in the realm of peptide chains. It's going to be secreted by the liver, muscle, fibroblasts, bone, and the kidneys in response to growth hormone stimulated DNA synthesis. So it basically mediates the actions of growth hormone. So growth hormone's one role is pretty much to cause the release of IGF-1. IGF-1 is kind of the effector of growth hormone's action. It is called insulin-like growth factor because it's related to insulin both structurally and functionally. It's a key growth factor. It increases muscle protein synthesis and hypertrophy, but it is also a very important neurotrophic growth factor. It influences nerve growth, neurotransmission, and the enhancement of cognitive function. And it does this in unison with BDNF, kind of similar functions there. So they work very well together. It's going to modulate synaptic plasticity, just like BDNF does. The density of the synapses, and again, to reiterate, synapses are the connections between nerves or between nerve and other tissues, and also heavily involved in adult neurogenesis. It's also critically involved in vascular maintenance and remodeling. So anytime we talk about vascular, we're talking about the blood vessels, arteries and veins and capillaries and whatnot. And we're going to talk about that importance in a few minutes here. We're going to see that physical activity enhances growth hormone secretion, which in turn is going to stimulate the production of IGF-1, which in turn stimulates the brain to release BDNF. So a key connection there between exercise growth factors and neurotrophic growth factors as well. So yeah, like we said, IGF-1 and BDNF are the key factors in the effects of exercise on learning and memory. So I highlighted the vascular role of IGF-1 because we also see that our next basic concept is also heavily involved with BDNF, and that's platelets. So platelets are the smallest formed elements of the blood. They're little tiny guys that are in your blood, and they're responsible for clotting. So if you cut your finger, please do not go, this isn't a suggestion, but if you were to have your finger cut and it bled for a little bit and then it stopped bleeding, what's happened is clotting has formed. So the platelets form this little, almost like a mesh web, almost like you would patch like a hole in drywall, like a little mesh barrier, and it attracts other proteins and things that kind of glom up, and they create a clot. They stop the bleeding.
So I have a quick interjection
Yes.
here. Now that sitting here thinking about how BDNF is stored in the platelets, which is what you're going to highlight right here in this section.
Yes.
I'm now questioning, my clinical brain is going, and I'm now questioning for, people who have had cardiovascular events. So like an MI, which is a heart attack, or even individuals that have had stents placed and they're prescribed an antiplatelet medication. I wonder if their BDNF levels are altered in some way because of that.
I would imagine, because 90% of blood BDNF is stored in platelets.
Interesting.
That is, yeah.
That's a question that I'm going to need to...
We're going to have to look into this, right. So what Jamie's getting at here is the elevation of platelets post-exercise especially is related directly to blood BDNF levels. And as we mentioned, platelets play a key role in the storage and transport of BDNF in the blood. So therefore, if platelet levels are altered or inhibited, what happens to BDNF?
Right.
Now, here's the thing. Platelet levels are going to be heavily modulated in a favorable way by habitual physical activity and physical fitness. So if we are very active, we're going to have good platelet function and subsequently good BDNF levels in the body. So those two are heavily connected. And even we see acute exercise. So acute versus habitual. Acute is going to be just one instance of something or one dose. Habitual is going to be over a long period of time. But even acute exercise results in a transient increase in platelet count and a BDNF response. So I would argue that, that definitely would be a connected factor. But subsequently, if we are engaging in habitual exercise and physical activity, our likelihood of a cardiovascular event goes down dramatically.
Absolutely.
So
yes.
we definitely see that connection there. We're going to touch on this back in the clinical corner segment later on in the show. Now Nice. So we're going to hand it over to Jamie for the final basic concept. She's going to talk about the stress hormone cortisol.
Yeah. So I think when we hear cortisol, everyone thinks of it as the stress hormone. Everyone thinks of it as a bad thing. I know it gets a bad rap a lot of the time, but it is a necessary hormone. We need it for bodily functions. It's released in response to physical or emotional stress. So physical stress could be anything that's happening to your body. Exercise is a physical stressor.
Mm-hmm.
And then emotional stress, we all know what that is, I think, especially as grad students.
No, I don't know what you're talking about at all.
But cortisol is released by the adrenal cortex, so in our adrenal glands. They're released by a diurnal cycle, so that's essentially just any pattern that occurs every 24 hours. So it's always being released every 24 hours. Its release is increased in response to stress and low blood glucose concentration. So again, that release in response to low blood glucose concentration is probably a good thing, because it's probably going to, as I'm going to go into in just a moment, going to eliminate those adverse effects that happen in the body due to low blood glucose. But if an increase in cortisol levels is prolonged, it can cause proteolysis, or the breakdown of proteins. Again, lysis is always going to mean breakdown. Something's, breaking down, it's getting rid of it, whatever it may be. And it also can induce muscle wasting. So that's where we hear those like catabolic effects of cortisol, because it is, that is detrimental to our body. We don't want muscle wasting.
If we think about this from a kind of evolutionary perspective as well, physical and physiological stressors to the body are what we call the fight or flight kind of scenario. And in ancient man, we could be just kind of hanging out on a rock somewhere, and there's a lion right behind us. If we were faced with a predator, our body would go, oh my God, we need to get out of here. And so in order to move quickly and survive, we would need to release energy substrate into the blood in the form of blood sugar, or get rid of excess things hanging around. So cortisol functions as a catabolic hormone to break things down. So it kind of furthers that fight or flight response that would serve us well. Obviously, we're not running from predators on a daily basis anymore as modern man. So it's used, like Jamie said, in an exercise capacity or a psychological stress environment. Sorry, turn it back over to you.
No, that's okay. Cortisol functions to increase blood sugar through gluconeogenesis, so kind of what I just touched on a little bit in response to that low blood glucose concentration. And it aids in the metabolism of fat, protein, and carbohydrates, our macromolecules, as well as decreasing bone formation. Cortisol prevents the release of substances in the body that cause inflammation, thus it has the ability to then weaken our immune system. So in response to exercise, like I said, a physical stressor, cortisol levels increase acutely. So again, right after that exercise bout, to meet the demands of the body. But that regular physical activity then leads to a decrease in cortisol chronically. So whenever we're in the exercise physiology field, we always have acute versus chronic adaptations.
Mm-hmm.
Acute, again, like Luke had mentioned, like I had just mentioned, something that happens after like a single bout of exercise or very, briefly post-exercise, whereas chronic is going to be those long-term adaptations that our body goes through. So again, cortisol levels increase acutely to meet the demands of the body, but then that physical activity leads to a decrease in cortisol chronically, especially at nighttime levels of cortisol, which is only going to be beneficial. We don't want our cortisol to be high as we're sleeping and trying to rest our bodies and recover. So the main takeaway about cortisol is that it's a necessary hormone. As we see, it has important functions in the body. I tell all my students all the time, the main goal in the body is to maintain homeostasis. If we didn't have cortisol, we wouldn't be maintaining homeostasis, and our bodies would not be happy and essentially not functioning. However, too much of anything can pose harm, just with anything else we ever talk about. So that concludes our break down the basics section.
Nice.
We are going to head into our lit review.
All right. I'm going to kick it off with a study that I found. Again, these are very recent studies. We try to go within the last year. So this was by Arazi et al. From 2021. And again, the references to these papers will be in the show notes that you can go check out on your own time if you want to read the papers in full. We're going to try to keep these, again, relatively brief, just hit the key points of each section here. And if you ever have any questions about reading a study or how to interpret it, please let us know. We'd be more than happy to kind of give you some guidelines on how to do that. That could be another great
That'd be a great episode
too, like a research in sport and exercise science episode.
Because reading research papers, peer-reviewed research papers, is not an easy task if you don't know how to read them.
Right, but we can help you.
Yes.
All right. So the purpose of Arazi et al.'s paper, they were wanting to examine the effects of both strength and endurance exercise on serum, BDNF, IGF-1, and platelets. So again, those three concepts we talked about. And they wanted to determine the association between these in older men. So a few cool things from this: aging population, because we mentioned the importance of BDNF in age. And I like that they looked at both strength and endurance exercise. So one of the things that we spoke with Greg about, and you'll see in the interview segment coming up, and again, those interviews occur whenever we have the time to meet with the person. So we might be recording those ahead of time. They usually are. A lot of the research has shown that endurance exercise has a more favorable effect on BDNF. So I liked seeing the strength training component included in this study. So let's see what happened. So they took 30 older men, and they wanted at least 10 years of basketball experience. And that really, that tickled me pink. I like that. They were healthy by self-report, so no medical examination, just probably a questionnaire of some kind. They had no cardiovascular or musculoskeletal diseases, and they weren't using any kind of drugs or supplements, which is, I think, impressive. A 30-person group of older people not using any kind of drugs or pharmaceuticals, like that's really good. And again, 10 years basketball experience, relatively active. We're starting to see some patterns emerge here.
Physical activity is good for you.
Exercise is medicine, baby. So they randomly assigned the three groups. They had a strength training group, endurance group, and a control doing neither. Those are equal groups of 10 each. We love to see equal groups. They use a controlled and randomized design. Again, those are also key things to look for in certain kinds of research. It's not necessary all the time, but for a lot of the ExPhys true experimental designs, we want to see a control group comparison and a pre and post randomized design. So for the strength testing, they had 3 visits, 48 hours apart. On the first day, they took anthropometric measurements, so height, weight, body composition, etc., and they measured their 1 rep max leg press, arm curl, and calf raise. Big 3.
The big 3.
Listen, I know a lot of our strength training friends out there might be a little grumpy hearing that, but the reason we use a lot of machine-based 1RM testing in exercise is that you can control a lot more than you can in like a barbell back squat. The amount of variability in movement pattern is so much higher in a free weight movement versus a machine movement. And these are validated testing measures. So I just want to throw that out there.
Also safety for participants, I would have to imagine. You know, it's going to be safer putting somebody on a leg press. They're not going to need to have as much instruction per se.
Right. We don't have time to teach them how to squat versus move your legs in and then extend them.
Exactly.
That's, kind of hard to mess up. On the second visit, they took 1 rep max bench press, knee flexion, and lat pull down. And on the third day, they trained for 45 minutes. They had 2 circuits of leg press, pull down, knee flexion, bench press, calf raise, and curl. They did each exercise for 10 reps at about 65 to 70% of the tested 1RMs. So we can see here, this isn't a training program. This is an acute dose of strength training. But even then, a circuit, that's not really what we'd call true strength training. I'd call that more strength endurance. But
I would almost say like the 3x10 range is like your typical hypertrophy that you hear too.
Well, they only did 2 circuits.
That's
true. They went around each. So again, kind of more of that endurance. But regardless, for the endurance group, they had 2 visits 48 hours apart. Day 1 was the anthropometric measurements, and day 2 They had 45 minutes of exercise, 3 bouts of 10 minutes of endurance exercise at 65 to 70% of their max heart rate. Again, that age-determined max heart rate. Control group did nothing.
Still important,
I believe they did collect anthropometric measurements for them.
Good.
Again, because you're going to do it for 2 groups, you got to do it for all 3. And for all groups, they collected blood samples pre and post exercise. So they looked at BDNF, IGF-1, and platelets, and they made sure that the post testing was within 5 minutes of the cessation of exercise to get those true post-exercise levels. What they find? Well, lo and behold, the control group had no significant changes from pre to post because they didn't have a pre to post. They just didn't really do anything.
Right.
The experimental groups had significant differences to the control groups for all the variables, which is, again, we would expect to see that. They saw small to moderate increases in BDNF from pre to post, small change in the endurance group, and a moderate change in the strength group. So I thought that was pretty interesting. But they found no significant differences in BDNF between endurance and strength at post. So again, we're looking at the within groups differences and then the between groups differences. They also found small to moderate increases in IGF-1 from pre to post. The endurance group had a small increase. The strength group had a smaller, moderate increase. And there was no significant differences in IGF-1 between the endurance and strength at post. All right, but strength did have a larger effect size, which is a statistical measure of the magnitude of the change, not just the significance of it. So always cool to see that reported. And in terms of platelets, they saw moderate, significant improvements in platelets from pre to post. The endurance group and the strength group both had moderate or large changes in platelets. But again, no significant difference between endurance and strength at that post measurement. They found significant correlation of IGF-1 levels with platelets and with BDNF. So we talked about those connections and how important they are, and this study kind of highlighted that fact. And they saw that serum BDNF, so the BDNF in the blood, was significantly correlated with platelets as well as with IGF-1. So what are the conclusions we can draw from this? Well, we can see that both acute strength and endurance exercise induces meaningful changes in BDNF, IGF-1, and platelets in older adults. There was no difference really between strength and endurance styles of training. I might surmise that this is due to the circuit style of training that we saw in the strength group. It almost seemed like a more robust bout of exercise than the endurance group was forced to do, or requested to do. They weren't held at gunpoint, I think. They didn't report that. And they found that IGF-1 correlates positively with BDNF and platelets. So again, kind of bring all those concepts together. I thought this was a really good study. I liked their study design that they did.
Yeah.
Again, I probably would have changed the strength endurance training to make them a little bit more separate. Yeah.
Yeah.
But again, that could be a follow-up study we could do in the future. We could talk about that more in the application section as well.
Yeah, absolutely. How does it say how old the men were, or just said older men?
I don't believe they gave a median age.
Okay. Just out of curiosity.
I will check on that again. If you're interested in that, I would look into the reference that we have listed. You can check the paper.
I'm sure they'll have like a demographics table or something.
Yes, probably.
Probably.
Yeah.
Okay, awesome.
Jamie, what study did you find?
All right, so I found a study by Garcia et al. It was actually published, I believe, I hope I'm not mistaking this, but I believe it was published in December of 2020, so really pretty recent.
Nice.
Within the last few months. I specifically chose this study because they touched on BDNF, the main topic of today's episode. They spoke about exercise, the other main topic about today's episode, and they looked at women, which was so nice to see because women are notoriously left out of research. So it was nice to see a paper just looking in women, especially since Luke's paper looked at men. So it's nice to have both. So the purpose of the study was to compare the acute effects of 2 exhaustive exercise protocols. So they had one graded exercise test, which or otherwise known as GXT, and one high intensity interval training session, so HIIT, that everybody knows and loves. And they were looking at those 2 exhaustive protocols on serum BDNF in healthy, physically active women. So they hypothesized that both the exhaustive exercise modalities would increase blood lactate and elicit a raise in circulating BDNF, because previous research had kind of tied those two factors together, saying, you know, the increase in blood lactate would then have like a directly proportional increase to BDNF. So the participants were 17 healthy 20-year-old female undergraduate students, so pretty small.
It's really the exact opposite population,
Yeah.
too, which is pretty cool.
Yeah. Pretty small and younger, kind of, you know, some of the youngest age groups that we see in research like this, undergraduate students. Each of the participants had a BMI of about 20 to 25 kilograms per meter squared. So they all were in the same relative BMI class. All participants were deemed physically active, again with use from a physical activity questionnaire, similar to the study that Luke spoke about. They had no pre-existing cardiovascular or respiratory conditions, and they had to be capable of performing maximal and or submaximal physical exercise. Both graded exercise testing and high-intensity interval training are taxing on the body. They can definitely, you know, especially graded exercise testing can definitely be considered a maximal exercise test, because you're essentially going until volitional fatigue. So getting into their methods, they had 3 separate visits to the laboratory. Baseline blood samples, heart rate, blood pressure, and blood lactate were obtained before testing on both of the days. Day 1 was just your typical familiarization session and informed consent. They didn't do anything during that day. They were kind of just, you know, told what to expect, what kind of exercise they were going to be doing, stuff like that. Day 2, body composition measurements and GXT testing using an electronically braked cycle ergometer was implemented, and we learned about our lovely electronically versus mechanically braked cycle ergometer, and we kind of see how an electronically braked cycle ergometer is superior, essentially because you can input what you want the person to do and it just goes, whereas the mechanical braked ergometer, you kind of have to keep changing the values to keep the participant going at the, you know, speed and cadence and watts and all of that stuff as the test goes on.
Right. The downside is that the electronically braked tend to be much more expensive.
Yes.
So depending on the size of the lab or clinic that we're in, you know, we could see one or the other.
Yeah. So on that day 2, that, you know, day 2 was technically the first day of actual testing, but regardless, each participant did a 4-minute warm-up at about 20 watts, so pretty easy. Workload then increased to 60 watts to initiate the start of the test, and then increases of 20 watts every 60 seconds until participants achieve volitional exhaustion. So even hearing that, like, that sounds tough.
Yeah, I see 1 or 2 bouts for me, I think.
Yeah, I mean, having done a GXT test myself on a cycle ergometer, that is no joke. It's tough.
You did great on it, though.
I don't know about great. I always like to joke.
I thought you did a fine job.
Well, thank you. I always like to joke that I have no type 1 muscle fibers left in my legs after being a powerlifter for the last 5 years. But regardless, so heart rate peak and blood lactate were recorded, followed by recovery heart rate at 60 seconds post GXT. So we want to see that, you know, drop off in heart rate after exercise. Total distance and work completed was recorded, and then blood samples were obtained 1 minute following the GXT protocol. So again, to get that, you know, immediately post-exercise value.
Can I ask a quick question?
Sure.
Did they mention a specific criterion for the heart rate drop-off that they wanted to see?
They did not.
Okay.
But I mean, there is a specific criteria.
So we want to see 42 beats from peak to 1 minute post?
I believe it's... Gotta look into it.
I think it's 42 beats per minute from whatever the peak heart rate was to... It might be 2 minutes post-recovery.
I think it's 2 minutes post-recovery is 42 beats, 12 minutes within... 12... Sorry, a decrease in 12 in the first minute.
Right, from the end of
Yes.
exercise heart rate to the first minute, and then I think 22 from the end of exercise to the end of minute 2. Or depending of, because unless that was the peak exercise when they stopped. In this case, it probably is the peak is at the end there because it was volition. But like a normal exercise bout, we would probably see peaks somewhere in the middle.
Yeah. And then it would kind of drop off.
Right, depending on what kind of modality we're doing.
Exactly.
Obviously.
Right.
But yeah, we do want to see a drop off. That's the reactivation of what we call vagal tone. Dr. Headley would be very happy if you heard us talking about this. So the vagus nerve is the major parasympathetic nerve. So the relax and recover nerve. So that is what takes over to take us out of that fight or flight stress response and bring us into a more calm, kind of everyday, lower heart rate, calm breathing, relaxed. And surprise, surprise, many people have difficulty getting in that state, especially after exercise. So if we can't have that heart rate drop off and the reactivation of vagal tone, that is a big sign of like cardiovascular mortality risk.
Mm-hmm. Yeah, that heart rate recovery is huge.
Yes. All right, sorry, continue.
So moving on to day 3 of their laboratory sessions, body composition measurement was taken again. I believe this was 1 week after the GXT session, if I'm not mistaken. And this was the day that they did the high intensity interval training or HIIT testing. So I have it written down right here. Completed 1 week after GXT training session. They had a previously determined like VO2 max that they were working off of, and it wasn't they didn't test it with a specific test. It was kind of just a calculation they did. So they warmed up at 40% of that previously recorded VO2 max, and then it was followed by a series of 30-second bouts performed at 90% of maximal aerobic power, with 90 to 120 seconds of active recovery at 40% of maximal aerobic power. So that is your, true HIIT style training. You're going almost all out for those 30 seconds, or, some people will do 15 seconds, 10 seconds, depending on what you're doing.
It's a million ways to organize it.
Right. And then that 90 to 120 seconds of recovery in between. The duration of this training, so the duration of the high intensity interval training, was equivalent to the GXT testing session. Heart rate peak, blood lactate, and heart rate recovery were obtained before the HIIT session and immediately after. RPE was also obtained immediately after finishing the last stage of exercise for both protocols. And for everyone who's not familiar with RPE, that's rate of perceived exertion. So that's just kind of a self-reported, how hard is this exercise, essentially. And then they use an ELISA, or an enzyme-linked immunosorbent assay, to determine serum BDNF. So they took those blood samples, ran it through the ELISA to look at their serum BDNF concentrations.
Can I ask you a quick question?
Sure.
Did everybody in this study perform the GXT first and then the HIIT testing?
Yes.
Oh, really?
I believe so.
Huh. Because I thought about that when you talked about the duration of the HIIT being equivalent. So they would need to have performed the GXT first to get that time. I don't know if I like that.
Yeah, because that's not really randomized.
The order of testing isn't randomized.
Right.
So what happens, dear listener, when we're organizing methods for a study, if we have 2 conditions that all participants are going to be taking part in, so kind of a repeated measures design, we want to counterbalance them, which means we want to randomize the order in which any participant is going to perform them. What this does is it reduces an ordering effect, which is, like it sounds, does the order of something have an influence on the statistical outcome? In this case, I understand why they did that, but let's hear about the results and see what happened. I'll be interested to see.
Yeah. So getting into the results, there was an interaction between GXT and HIIT on the mean blood lactate levels. So blood lactate increased from pre to post exertion in the GXT and HIIT training styles. Post exertion values were considerably higher in the HIIT compared to the GXT condition. And after that, there's about no interactions with anything else.
Wow.
So there were no interaction between GXT and HIT trials and measurements of BDNF. No interaction found between GXT and HIT on serum cortisol concentrations. The cortisol increased regardless of the type of exercise performed, which is kind of to be expected.
Sure.
You know, we're pretty much always going to see an increase in cortisol after any bout of activity because it's a physical stressor. There was no interaction between GXT and HIT and the cortisol to BDNF ratio. So it increased following exertion regardless of the trial performed. The magnitude of change was larger in the HIT versus GXT, but I guess nothing to be significant, so to speak. And then there was no interaction between the two exercise trials on heart rate values. And this goes to show that you have to report everything, because when I read this, I was like, no kidding, that heart rate at baseline was lower than values recorded immediately following exercise. But again, in research, you have to report everything.
If I can ask a quick question,
Yeah.
Or reiterate something, that magnitude of change being larger in HIT versus GXT that wasn't statistically significant, that's another example of that effect size that I mentioned in mine. So anytime we see magnitude of change, that's going to be the effect size versus a statistically significant change.
Got it.
Which is something different.
Clearly, Luke is the research expert in this household.
It is my job. I literally teach it once a week, so I'd hope I know what that is.
But that's good. Thank you for clarifying that for me and for our listeners.
Yes.
So essentially, the conclusions that we can come to, or the researchers came to, was that acute exhaustive exercise did not change significantly circulating BDNF following training, and cortisol did increase after both bouts of exercise. And they speculated that this could explain, so that cortisol increase could explain the lack of effective exercise on the circulating BDNF, because they are linked, that, you know, the increase in cortisol might alter the increase in BDNF serum concentrations. I definitely want to look into that a little bit more.
I gotta imagine that's on an acute basis, though, not that constantly elevated cortisol, which would be almost the opposite.
Right, exactly. We can also conclude that the high intensity interval training greatly increased blood lactate more than GXT, which was an unexpected finding since the work and distance performed were similar between the two protocols. But just goes to show that different protocols are going to have, you know, different effects on the body. The speed revolution was higher in the high intensity interval training. Therefore, it's possible that the muscle contraction rate was greater in HIT versus GXT, enhancing the metabolic process in interval training, which could be why blood lactate was increased more in the HIT style versus GXT style of training. And then functional capacity, so essentially just VO2 max and physical activity levels, and the BDNF response may be inversely related to circulating BDNF levels, which could be why there was a lack of BDNF response in this population, as they were already all physically active individuals.
They might have been taxing them enough to see kind of response. Yeah.
So yeah, I mean, any other questions from you?
So as we were going through this, I was thinking about my previous grievance about the ordering effect, but I guess if they had a week-long washout period between the two protocols,
right,
that probably wasn't enough time.
Right, fully recovered from the training session.
Did they ask the participants to refrain from any outside exercise during this time?
Yes.
Oh, okay. Cool.
Yes. So they were, I don't remember the exact parameters, but I believe they were told not to participate in any form of activity before coming in for the training session. Not only because that could potentially affect the results of their test, but also because they took measures of body composition before each testing session,
right,
and that could also alter that.
Right.
So I believe they were asked not to perform physical activity, no eating or drinking for 2 hours beforehand, no caffeine. So yeah, they definitely did. They had certain parameters that they had to follow before testing.
Okay, all right. Rescind my previous comment, I guess. You know.
I think it's still a good comment and a good observation to make.
It's always good to look at these things with a critical eye.
Yeah.
And just part of that is knowing what to look for, which just comes from reading a million studies and learning about it. So definitely, again, we implore our readers, or listeners rather, read as many studies as you can, start seeing what patterns you see emerge in terms of methods and whatnot. And that'll only increase your ability to function independently and not have to rely on other people to tell you what a study means, but you can actually kind of learn for yourself, which is always good. Do you want to move on to our next segment?
I would love to.
Okay. So would you like to address application time or clinical corner first?
Say clinical corner. I want to revisit my question from earlier about patients with cardiovascular disease who have had. I want to talk through this and see if it makes any sense. Yeah. So for those of you listening, patients that have had, or individuals, I should say, not necessarily patients, who have had a cardiovascular event, so a myocardial infarction, or that's a fancy word for heart attack, or if they've received any form of stent to alleviate a blockage in one of their arteries, they might be on, or they will be on medications that essentially they're called blood thinners in layman's terms, antiplatelets. So my question from earlier was, if they're on these antiplatelet medications, especially if you've received like a stent or a valve replacement. So we have like tissue versus mechanical valve replacements, and those mechanical valve replacements are metal. We need that antiplatelet essentially forever to make sure that our blood doesn't stick to those new valves. Mm-hmm. So I really am curious as to if that would decrease their levels of circulating BDNF, and would that then lead to, or have the potential to lead to, cognitive impairment and cognitive decline maybe sooner than a healthy population? I don't know.
That's a good point. So those blood thinners like Coumadin, warfarin, probably going to be the most common.
Yes. So Coumadin, I believe, again, not a medical doctor.
None of this is medical advice.
Right.
Just speculation.
Just speculation. Just going off stuff that I've seen, in a clinic versus learning in pharmacology courses and so on. So warfarin or Coumadin is the kind of trade name for it. That's a typical protocol after like valve replacements. I believe that one is actually anticoagulant, not antiplatelet. Okay. So there's a difference.
Right.
There's, coagulation of blood, or like the
formation of a thrombus.
Yeah.
Really.
Yeah. So that's kind of eliminating that, versus antiplatelet is more of your blood thinner. So like your aspirin, like your typical baby aspirin,
right, is
like the most basic form of blood thinner. And then we have, other things like Eliquis. I want to say Plavix is one of them. That's pretty common. I think everyone's seen a Plavix commercial.
Oh, what is the other one? Begins with an L.
Oh boy.
Lasix.
Yeah. No, Lasix is a loop diuretic.
Oh, you're
furosemide.
Right.
Yeah.
Right.
Yeah.
But so the anticoagulants then, are those probably interfering with like endothelin 1, thromboxane A2, like are coagulating agents?
Yes.
Okay, as opposed to platelets in particular?
Yes.
Okay.
Yes, because then like the subcategories of those anticoagulants would be like the thromboxane or XA, I can't remember off the top of my head, inhibitors or something like that.
Yeah.
But yeah, so I'm more thinking about the antiplatelets, since we spoke about
sure
like BDNF existing in these platelets. So
so we had kind of touched on this yesterday. We were speaking about it, but I also wanted to look at it from the population at risk for a cardiovascular event. Generally, and again, I am painting with a very, very broad brush here, but generally are those who are less physically active, especially in their later years. So we see that a lot of the lifestyle-induced risk factors which are the main cause of most cardiovascular events. There's a few congenital issues which could manifest in like childhood or adolescence, but the majority are going to be in adulthood because of lifestyle changes or lack thereof that we see. Like unfortunately, obesity is a comorbidity for just about everything in terms of cardiometabolic conditions, unfortunately. And the number one thing that can reduce that is regular physical activity. So, kind of a chicken and egg situation of, and one hand washing the other, of does physical activity increase platelet count in a safe way? Or consequently, does a lack of physical activity allow for platelets to run rampant in a condition like atherosclerosis, where a clot is going to form because of platelet aggregation due to other chemical signals going on in the area? So I think the conclusion could be that if we're physically active, we're better off than if we're not. Obviously, no kidding. You don't need the podcast to tell you that.
I think we get to one of those like pros and cons type of things, that like the pros of physical activity are always going to outweigh like something like this. Like maybe it's going to outweigh the con of maybe the BDNF rise isn't going to happen as much in that population. You know what I mean?
Yeah, I mean, even just maintenance of existing levels is fine.
Right.
And
I want to touch on what you said before about cardiometabolic disease, because it's no secret that obesity is a risk factor for developing type 2 diabetes, which is seen in probably the majority of people that have experienced a cardiovascular event. It's probably one of the greatest predictors that you're going to have a cardiovascular event.
Absolutely.
But going back to the BDNF thing, I had come across a link between BDNF and type 2 diabetes, that type 2 diabetes might already kind of decrease. Again, don't quote me on this. This is definitely not my area of expertise in any way, shape, or form, but that type 2 diabetes may already mitigate some of those circulating BDNF responses in general, or you might have lower levels of BDNF in the presence of type 2 diabetes in general. So that might even precede that whole question that I had with like the whole antiplatelet thing and, this population and blah, blah, blah,
Right. So it's really which one comes first.
Right.
I guess that's interesting to look at.
The chicken or the egg?
Find that paper, and we will put that paper in the recommended readings of the show notes as well. That's really fascinating. Definitely some cool clinical implications there as well. Some potential follow-up studies, which kind of leads us into our application time. So like, what do we do? How do we take this information that we've learned? Obviously, Mr. Greg Spicer is going to talk about some of his thoughts on the subject in a few minutes when we do the guest segment.
Yeah.
But we can kind of muse on the findings of these studies and what we talked about in the basics, break down the basics segment. So what do you think the biggest takeaway from these studies are, Jamie?
Physical activity is good for you.
Excellent. End of podcast. No, just kidding. Yeah, I mean.
But really, yeah. I think that's the biggest takeaway from pretty much anything we're ever going to talk about. If you're not physically active, you should probably start doing some activity.
Yes.
I think people like underestimate what is like good enough for physical activity, and I think
anything.
Right. And I think that people, if they're not, there are some people that just don't like exercising, and that's okay. I don't understand, but it's okay. And I think they hear physical activity and exercise and all of this, and they get very overwhelmed very fast, and that leads them to just not do it, which is understandable. However, if they knew that, and we're here to tell you that even if you just get up and walk, that is already so much better than nothing. What's
the old, even if you're going slowly, you're still lapping everybody on the couch.
Exactly.
Kind of mentality.
Right.
I wanted to touch on this before I forgot. When I gave that talk at Springfield about the physiology of aging a few weeks ago, one of the questions after the presentation was from a very nice staff member, and she was not an older person. She probably late 30s, early 40s, I want to say, but just was concerned with the decline in physical activity, her personal decline in physical activity during the quarantine, especially. And she didn't know enough about exercise to do anything at home by herself. And so she was afraid of doing something incorrectly and then getting hurt.
Right.
So she didn't do anything, which I understand that fear and that trepidation.
Absolutely.
Which I would respond to, and I think I did. You know, there's a million things online that we can look for. There's plenty of YouTube instructional channels out there, many of which are decent, some of which are not, but we're not going to name any names here.
If you ever had any questions about some decent ones,
yeah, let us know.
Let us know.
And we can guide you in the right direction. Them. You know, and we don't need to get an online coach for basic fitness.
Right.
We can go very, very far with just our own 2 hands and 2 feet.
Yeah.
You know, walking, running, basic bodyweight fitness. There's a million things we can do to stay fit. Luckily, I think with the vaccine rollout, in the hundreds of millions now, which is fantastic.
Yeah.
We really should be seeing more places open up, or at least the fear of going into more public places decrease, which is great. So, like Jamie and I both said, do something. It's better than doing nothing.
Yeah.
Start sooner rather than later, because it's much easier to prevent than it is to reverse, especially in older age. And I don't want to seem biased because I found this article, but I do think that the conclusions of Arazi et al., the study I brought up, kind of had a little bit more of meaningful implication.
Absolutely. Yep.
In talking about that aging question. So we had a physically active older population that had great responses to exercise still. I would love to see a comparison of the same study protocol performed in a non-active, like matched cohort.
Yeah.
To see what those responses would have been. I gotta imagine, based on what we spoke about today, it would have been rather different.
Yeah, I would imagine so. I think touching back on like the, physical activity and doing at least something, I recently gave a presentation to some of the patients at the cardiac rehab facility that I'm interning at about exercise and technology. Again, probably wasn't everybody's cup of tea. I know older populations don't really love relying on technology for things, but it does have some really great benefits. And one of the tips for getting that physical activity in was to create like friendly competition. Get a family member, get a friend, and say, for this month, let's keep track of how many steps we take, and give some incentive, do a gift card, do something. I get that that's that extrinsic motivation a little bit more than intrinsic, which we don't always love to have, but if it's going to get you up and moving, it's worth it, and it'll help you develop those habits then that you can then continue on with even after your little step challenge or whatever it may be.
Yeah, not everybody is going to rely on the same kind of motivational factors as anybody else. So if it works for you, honestly, roll with it.
Right.
Anything else to add to this?
I think that's pretty good.
We talked about most of the things we wanted to touch on.
Yeah.
We're going to wrap up this segment, and we're going to move right into our guest segment now.
Our guest today is Greg Spicer. He's currently a PhD candidate at Springfield College, where his research focuses on cardiovascular and neurological responses to exercise. Please welcome Greg Spicer. Greg, how are you doing today?
I'm great. I am just thrilled to be here to talk about exercise and physiology and hang out with you guys for a little while. So thank you so much for having me.
Well, thanks for being a guest, Greg. Why don't you tell our listeners what your overall field or focus is at the moment?
Yeah. So hi, listeners or viewers or whoever you are. I am currently earning my PhD in exercise physiology. So in short, I study the effects of exercise on the body. That involves the acute responses and the chronic adaptations, but my, research focus has been the acute response to exercise or acute responses. So my concentration within that has been looking at the effects of exercise on the cardiovascular system. And for my dissertation research, it's been how does the cardiovascular system impact the brain's function, and how are those systems impacted by exercise? So yeah, I'm just very passionate and interested in how exercise improves the body's function. I mean, you talk about hitting two birds with one stone. Well, it just seems like exercise is, I just continue to read about more and more birds that exercise can hit, you know? So it was a really weird way of putting it. I didn't write that down, but anyway, yeah, that's kind of what I'm about. I just, I love exercise, and that's kind of what my dissertation has brought me to. So
can you give the listeners kind of a preview of some of those cool brain interactions that we do see during exercise?
Yeah. So, I mean, as if we didn't have enough reasons to exercise already, right? We know, I think at least most of us know its effects on the cardiovascular system in terms of like blood pressure, and risk of heart attack and stroke and things like that. Well, exercise improves the function of the brain in several ways. So, I guess my focus has been seeing how exercise impacts state anxiety as well as working memory. And it seems that exercise improves both of those. That's pretty widely accepted. So I guess my interests are how does exercise do that? Like, what are the underlying mechanisms of how that's accomplished? And how can we tailor our exercise to, I guess, maximize the benefits? So does that come down to exercise intensity or duration, or some other type of factor, right? Like interval training. So that's kind of what I'm interested in. So yeah, exercise is, it seems pretty well documented that it's beneficial for the brain's function in several ways. And those, I guess, are my specific interests.
What drew you to this area in the first place?
To like exercise or to
brain function specifically? Yeah.
Oh man. You know, I forget exactly like what got me like started down the rabbit hole. Dr. Headley, our advisor, played a role. I guess we were talking about how we might be able to collaborate with a nearby hospital like Bay State to do some sort of joint study and use like equipment that they have to assess like brain function. Obviously that would involve the like equipment that we don't have on campus. Mm-hmm. And while that seemed really exciting, I guess I made a compromise and looked into how we could assess the brain's function without collaborating with them. Nothing against them, but I guess my interests were, I guess I prioritized finishing things up sooner rather than later. And I guess I made the decision to look into measuring some sort of brain variable, like in-house. And so once I learned, I guess upon reading more about brain-derived neurotrophic factor specifically and seeing how you can measure that through like a blood draw, that kind of changed the game. It was like, wait, like I don't need to collaborate with Bay State or some other hospital and go through all the hoops of like IRB approval with them to assess brain function. And so that was a huge, I guess, step in the right direction towards like what I'm doing now, is learning that I could look at the brain indirectly through a blood draw, which is, I think, pretty cool. So
absolutely, yeah. So is that an assay that you're running with the blood sample?
Yep. We ran over the last few weeks. We ran 6 different kits. Actually, we had to redo one of them, so we ended up doing 7, and that was just for BDNF. So we have 6 more kits that we have to run to assess serotonin in the blood too. So that's another variable that my dissertation is, well, not my dissertation, but I guess the work that I'm doing with another student to look at. So
awesome, cool.
Yeah.
What's the current state of the field, especially related to like brain responses to exercise? What have you found? Any gaps? Anything that needs to be addressed?
Yeah. So my focus in exercise and brain function is really tied into a protein called brain-derived neurotrophic factor. And so I can definitely speak on behalf of that protein. The brain is really difficult to talk about because it's just so complex. It's just so, it's a really advanced topic. And I can definitely speak to this just one little tiny protein that the brain produces. So it's pretty widely accepted that exercise improves or increases levels of brain-derived neurotrophic factor, or BDNF, and that's a protein that the brain produces, which basically facilitates all kinds of cool brain things. That's how I grab people's attention. Is it does all the brain things that you want that you could want a thing to do. So your brain is essentially a collection of neurons, and depending on where those neurons are located in your brain, those centers or those groups of neurons are responsible for different functions, right? And so what BDNF does in certain regions of the brain is it leads to the production of new neurons, which we didn't think was really a thing. So that's like neuroregeneration, neurogenesis, so the formation of neurons that already exist. And then it increases the connections between neurons. So it's like synaptogenesis is another term for that. It's involved in synaptic plasticity, which is essentially affecting the strength of the connection between neurons. So it's really kind of the nuts and bolts, or at least this protein is one of the nuts or bolts that's underlying how the brain responds to exercise. So the brain produces this protein in response to exercise, and that's one of the factors that's involved in facilitating these functions like working memory and state anxiety and so forth. So it's pretty widely accepted that BDNF is at least dependent on exercise. It's dependent on other things, but I guess what's not as well understood is how can we tailor our exercise to maximize the benefits of BDNF? And I guess what other systems are involved? Like, does the cardiovascular system play a role in its production? So that's basically where my dissertation is hoping to kind of fill some gaps. So I can definitely, I guess, speak to those gaps, but I mean, there's probably a whole lot more that I'm forgetting at the moment. So
awesome. I know I'm really excited to see what you get out of this, and hopefully it's something good.
Yeah.
What future directions are you hoping to take, whether, with your dissertation or just in life in general, post PhD?
What a loaded question, right? What's all this going towards? Yeah, man. I have a tremendous opportunity to take my talents to UMass, or I guess my perceived talents to UMass Amherst. I have a postdoc position lined up, so a postdoctoral research fellowship lined up at UMass Amherst.
Awesome.
There I'll be doing some muscle physiology research. I haven't, I guess, been, I guess my exact role, my exact responsibilities haven't been laid out in front of me yet. They do all kinds of cool things looking at how muscle works. So it's very, very, very basic research, very experimental research on actual muscle fibers. And they're able to look at a whole slew of variables from the, techniques and equipment that they have there. So interestingly enough, they seem to be open to the idea of me continuing my interest in BDNF. And I guess you might think, like, how would that have to do with muscle? But it turns out that brain-derived neurotrophic factor can actually be produced by muscle. So I don't know if they should be talking about muscle-derived, brain-derived neurotrophic factor, or if they should just call it something else.
One big acronym.
So it's actually
right? ND, BDNF. Yeah, I don't know.
By the time this airs, our listeners will be hearing this in reverse. We've recorded this interview before, obviously, the episode actually airs. We'll have spoken about how some research has found that it's produced by muscle fiber RNA. So that's a great point that you brought up. I was actually just about to ask this. And actually they found that they can rescue motoneurons from apoptosis, not just brain neurons, but motor unit neurons as well. Which is fascinating, which I think ties in the cardiovascular aspect nice. So it's, does the cardiovascular system help, or is it a facilitator of movement thereof?
Yeah.
Which is interesting.
Man, that is just so cool. Yeah, it's little things like that where it's just BDNF is just this one little tiny little player in this game, right? And I just find its effects so interesting. It just continues to add, I continue to learn of reasons how it's beneficial for the central nervous system and apparently the peripheral nervous system. So yeah, that's super fascinating.
In your dissertation, you were looking at HIIT and mice, correct?
Yep.
I should say for our listeners, we're not talking about the little furry mammal. We say mice. We're talking moderate intensity continuous exercise.
Yep.
Okay, correct.
Yeah.
Now, have we found, is there any research on resistance training, or is it mainly aerobic style? Because I know that the PPAR alpha gene actually modulates the BDNF gene expression, and we know that, well, we know here, maybe our listeners don't, but PPAR alpha is expressed heavily in type 1 endurance fibers from heavy aerobic training. So do we see any kind of crossover with resistance training?
Yeah. So as far as I know, aerobic exercise seems to be best for the production of BDNF. I find that question really interesting. I guess I find the idea, or I guess the focus or concept of like exercise mode or exercise type, like super important. I don't think anybody should be specifically training in any one mode. I think it's of the utmost importance that we, I guess, train in different ways to reap the benefits of different types of training. I guess with that being said, it seems like BDNF is more so impacted, or its levels are more so impacted by aerobic exercise. But that doesn't mean to put the dumbbells down by any means. You know what I mean?
I wasn't going to.
Yeah, no, me either.
I'm not. Yeah. Just for our listeners, you know what I mean? I can't steer them in the wrong way. You know.
I'm wondering now if the old kind of thinking of, go for a light run, clear my head. I'm wondering if that was all along tied to an acute BDNF response, that we find we can think clearer, make better decisions, remember things, study. Like, I wonder if that's the connection there. That would be fascinating.
Yeah. I mean, if you consider like your, I don't know if mood is the best way to put it, but your awareness, your ability to comprehend, perceive, and focus. I mean, take working out in the morning. Like if you're not somebody who works out in the morning, I don't think, I guess I'm of the belief that a nice like dose of exercise is just as effective as a cup of coffee, without some of those jittery side effects. But I definitely agree with you that I guess clear your head, or like reset your mood, or reset your mind, or get your mind off of things. I mean, it wouldn't surprise me at all if there's research that backs that up and correlates it with BDNF. So
anecdotally, when I started doing 20 minutes on the bike in the morning, especially before stats at 8 a.m., I found an immediate increase in alertness and attention, which, like you said, like kind of equivalent to a cup of coffee. It's like you're getting that sympathetic response. So, you're having increase in heart rate, oxygen uptake, all these things that we associate with what caffeine would do as a stimulant. So that's a really cool connection.
And you brought up the point of resistance versus aerobic exercise. And I think one of the key players that's involved with aerobic exercise is obviously blood flow. And that's why that's one of the reasons why my interests include like the cardiovascular system and the brain, is because it does seem like aerobic exercise has something that resistance doesn't. I mean, obviously it has several things, but in terms of brain function, it seems like the flow of blood to the brain is impacting its function. And like, I just think that's super cool. I mean, I'm not putting my dumbbells down anytime soon, but the impact of blood flow to the brain and its ability to do its job. I mean, it's not its job, it's jobs. I just think that idea is fascinating. Like, that is just such a cool thing to me. So, and it seems like higher intensities of exercise are better, but that's one of those, it's one of those things where you find conflicting results, and that's why I'm doing research, is to get more evidence for it. But yeah,
it's a great time to remind our listeners that one piece of research does not prove anything. No pieces of research prove anything. Like, I think we actually mentioned this in the last episode too. Right. It's just, it gives us one insight, especially if you look
once you get into the statistical analysis and study design aspects of research, it's like, this is what happened when we were operating within very, very, very like strict parameters that we did not deviate from. And if you change one thing, well, now all of a sudden it's a different finding. You can't just compare apples to oranges in that way. So it's really important to remember that, you do one study, you find it, somebody else could replicate it and find something completely different.
Right. Which is why I think that if you ask any researcher, any scientist a question, they're always going to answer with, it depends. I know it's like sometimes it's the most annoying answer to get, but a good researcher, a good scientist is going to say it depends, because it does. And it depends on who you're looking at, what conditions you're looking at. So many different things play a role in the findings. Yeah. So that's another good point to make, I think. I'm
loving these interviews because we're learning stuff as well.
Yeah.
Like, we're getting this insight from people who are actually handling the data and the blood that the stuff is in, for God's sake. So really just really great information here. Greg, where can people find you if they want to know more?
So I gave you my email, so feel free to post that wherever. I recently deleted my Instagram, so unfortunately that's not a way to reach me, but I check my email regularly, so like feel free to hit me up on that. I'm on Facebook too, so like feel free to search my name and I should pop up. So feel free to reach out to me. I love talking exercise. I love talking in general, so hit me up.
We'll throw your email in the show notes so that people can find it there and easily reach out if they want. Jamie, do you have any other questions? Anything else to bring up?
No, I think we covered a decent amount.
Good. Greg, I think I cut you off there. Is there anything else you want to add before we wrap up here?
No, I'm good. I was just kind of adding to that point of it's fun to learn about these things. It's important to I guess take everything with a grain of salt. And to use, I guess I find it important to use a certain language when talking about these things. It's, I happen to have read articles that tend to say a certain thing, or like based on the articles that I found, most of them say this type of thing. But we're all out here just trying to learn, and we can't, I guess there's some things that maybe we'll be convinced of, but I guess like how we judge that or how we make our decisions is, I guess what makes learning like fun and interesting,
Absolutely. I think we have somebody who wants to join the guest segment here on your end. It's okay. We are a dog-friendly podcast.
Yeah. Actually, our feedback from the last episode was that they wanted more dogs.
More dogs.
So here you go.
All right. Well, listen, Greg, thank you very much for talking with us today, and look forward to speaking with you soon.
Yeah, thank you so much for having me. Sorry about that, guys.
That's okay.
It's been an honor. I really enjoyed talking with you. So, enjoy the rest of your day.
Thank you.
All right.
You too. We are going to head right into our question and answer section. Luke is going to start us off by answering a question by @Helene of Troy. She would like us to talk a little bit about muscle spindle fibers and GTOs, or Golgi tendon organs.
All right. So these are both little guys that are found in our muscles and tendons, as the name kind of suggests, muscle spindle fibers, Golgi tendon organelles. So they respond to different kinds of mechanical stimuli. So the muscle spindle fibers are going to respond to changes in muscle length. So if we think about doing a dynamic movement like a heavy squat maybe, what happens is when the muscle is stretched under tension quickly, these muscle spindle fibers actually sense that change in sudden length and respond by activating motor neurons to elicit a contraction.
Hey, we spoke about motor neurons earlier.
Yes, we did. Right. So it's all coming together. So that's what's known as the stretch reflex. So we have a sudden stretch, and the reflex is then to contract the muscle to produce force. So what gets us out of the bottom of a squat, or if you think about like a depth jump, like stepping off, landing, and then immediately jumping up, same kind of stretch reflex is being activated. The Golgi tendon organelles are found in the tendons as opposed to in the muscle belly proper, and they respond to changes in tension to the tendons. So if we are pressing a heavy bench press rep away from the chest, and we're talking like a near maximal or maximal load where we kind of get stuck at that sticking point, we're pressing. A beginner lifter will reach that point, and the Golgi tendon organelles will actually sense that tension, and they will shut down force production. And the bar comes back to the chest, we failed the rep. So one of the side effects of long-term strength training is a deconditioning of those GTOs, the Golgi tendon organs, to kind of circumvent that process so that we can safely, as we call it, grind through the rep and continue producing force even under that heavy tension. So that's one of those neurological adaptations that occurs even within 6 to 12 week period. Normally at the first 12 weeks of resistance training, all the adaptations that get us stronger are all neurological in design and not so much architectural, like any changes to muscle size or density. That's going to come after that period. The neurological adaptations, basically your body learning how to move effectively under load, those are going to come first. Something else about the muscle spindle fibers before we move on from this. When we think about static stretching, this is often a mechanism that we have to take into account, which is one of the reasons that the community really shies away from and advises against ballistic stretching, a very dynamic, sudden force, because we're not really allowing the muscle to passively lengthen so much as just kind of taking advantage of that stretch shortening cycle rep after rep, and potentially putting the muscle in a dangerous position. So a really good way to stretch is the PNF, the proprioceptive neuromuscular facilitation. So proprioceptive because both of these muscle spindle fibers and GTOs are muscle proprioceptors, so they sense changes in where the muscle is in space and what it's doing. So in PNF, for example, if we wanted to perform that on the hamstring, we could lay on our back, relax the off leg, relax the leg that we're being stretched with. Partner would keep the knee straight and move the leg up till that R1, that point of first resistance. And then we would actually have a contract relax pattern between the person being stretched, contracting against resistance, and then relaxing to allow that stretch go further. So we're basically kind of circumventing the muscle spindle fiber response to actually stretch the muscle and get a more complete range of motion. And then, of course, whenever we static stretch, we don't want to do it immediately before a maximal effort lift. We want to do it probably at the beginning of our session, if anything, get that length, and we need to immediately ingrain it in some kind of loaded movement pattern. So if the goal would be, stretching the hamstrings, we do PNF in the hamstrings, and then some kind of loaded hip hinge would probably be the best thing to do to then ingrain that pattern under load.
I think that's one of the main takeaways that we've gotten over our years of education is that, stretching, I feel like stretching gets a bad rap a lot of the time. And I think it's more that stretching incorrectly should be getting the bad rap. And a lot of people don't understand that stretching without actually doing anything afterwards to then fix those movement patterns is really not going to help you all that much. So when you're stretching, you need to be following it with, moving in the optimal pattern or working under load, something like that, to fix what is the issue in the first place.
The effects of stretching, the increases in flexibility and range of motion, are transient. So they're going to last about 30 to 90 minutes versus an actual physiological adaptation from long-term training will last, indefinitely until the stimulus stops being applied. So really, I kind of liken it to, if we're trying to dig a well, we keep digging a hole and filling it with water. Until we line it with stone, the water's going to keep just draining away. So it's one thing to stretch, but then we need to immediately load the pattern. And again, I'm sure there are many people out there who just refuse to see the benefits of stretching at all. And some people who only see the benefits of stretching. As usual, the answer is somewhere in the middle, in the gray area, and it's all contextual, depending on the context of what we're trying to do. Jamie, our second question comes from @MStamen. These are all from Instagram. We do encourage, obviously, our listeners to leave us any questions. It could be anything. Doesn't have to relate to the episode. Any question, all you want answered. We'll do our best. She wants to know a little bit about exercise-associated hyponatremia and sodium's role in that.
Yeah, so if we break it down, exercise-induced, that's pretty simple to understand. What is exercise causing in this situation? And then hyponatremia. So if we take hypo, we mean we know that means like less than the normal amount that we want. And then natremia is going to relate to sodium. If we think of Na as our, let's bring our periodic table of elements out here for a quick moment. Na is sodium. So we have hyponatremia. When we talk about, and hyponatremia can occur in a variety of populations, but for this specifically, let's kind of highlight athletes because we're talking about exercise induced. So there's 3 things to really consider here. We want to consider the length of the activity. So if you're an athlete, length of your practice, length of your game, your scrimmage, whatever it may be, length of your lift. We want to think of sweat rate. So that's going to depend on the athlete. It's going to change from person to person. Some people sweat a lot. Some people sweat from just simply existing, and other people don't. So that's definitely going to be very variable between people. And then we also want to take into account sweat sodium content. So is your sweat salty? Which, like, as gross as that may sound, it's like, really, like, taste your sweat. Is it salty? That's a good indication of, how much salt you're excreting from the body. So exercise-induced hyponatremia essentially means that you are excreting more salt than you should be during exercise without replenishing that sodium content. And the research seems to be a little bit conflicting in this. Some researchers think that this is due to overhydration, where you're taking in too much fluid and you're retaining a lot of that fluid, but then you're still excreting that sodium. And then some researchers think that this is due to dehydration. So you're just excreting way too much fluid, way too much sodium out of your body through your sweat, and again, not replenishing enough of that sodium, leading you into that hyponatremic state. So again, not a doctor, not a coach, not anything, related to this field that I could give concrete advice on. Definitely do your own, peer-reviewed research about this. But it seems like general guidelines are to be taking in, 3 to 8 ounces every 15 to 20 minutes of like a sports drink, not just plain water, because then you're not getting your sodium content that you need. But anyway, yeah, anything you want to add?
No, I think we did a pretty good job with that.
And Luke is going to answer our last question of the day from @jpim_lifts. He would like to know a little bit about blood flow restriction training.
All right. So blood flow restriction training, or BFR, it's basically we take some kind of cuff, we place it over one of the limbs, either the arms or the legs, at the most proximal portion, so right underneath the shoulder or right below the hip, and almost like a tourniquet, it's going to cinch tight, and it's going to act to restrict the flow of blood in and out of that region of the body, as the name suggests, blood flow restriction. So this operates under the physiological principle of occlusion, so basically blood being trapped in one region and not being able to leave. So what this does is it actually causes an increase in cell swelling, the concentration of hormones and other metabolites that are in that region, and leads to hypoxia. So we don't have fresh oxygen-rich blood coming in to the region. So it's a buildup of low oxygen blood, hypoxia. So most of the research has shown that this kind of training is really beneficial in the 20 to 30% of 1 RM range. Now, this is a range that really wouldn't normally be enough to elicit any sort of adaptation, other than a very mild kind of endurance adaptation. But due to the introduction of the occlusion to that area, we actually do see beneficial increases. So some of the key hormones that are built up are things like IGF-1. We see an increase in that concentration, increases in hypoxia-induced factor 1 alpha, so HIF-1A, and accumulation of other metabolites such as lactate, and all these things built up in those regions. The swelling of cells with blood and fluid is going to increase circumference of the muscle, and actually the activation of type 2 muscle fibers during the period of exercise, which is pretty cool. We do want to make a big caveat here. Do not engage in BFR training if you have a history of thrombosis. So those clots we talked about earlier, you could die. So please do not engage in that sort of training. I actually spoke a little bit with a good friend of ours, Zhengyu Zhang from Springfield College. He is doing, or just finished his master's thesis, which was centered around blood flow restriction training. So yeah, he definitely recommended using an FDA-approved device, something like
don't create your own
right, exactly
at home,
right.
You know,
he said Smart Tools is pretty good. Comes with everything, instruction and whatnot. And he also recommended measuring your limb occlusion pressure if it's feasible. It's for a more precise prescription of blood flow pressure, blood flow restriction pressure. So it should be about 68% of that limb occlusion pressure. And he also recommended using a high pressure intermittent BFR instead of a low pressure continuous. So the high pressure intermittent, he says, is less likely to exaggerate any acute cardiovascular responses at a lower RPE. He says that BFR really could apply to a variety of situations where we need to improve the efficiency of training or avoid high intensity exercise. The clinical populations are huge for this. So if we have a population that needs some kind of resistance stimuli, but they can't really handle a heavy load, this could be a great alternative to almost simulate that. And much literature has shown that in that 20 to 30% range can actually cause some pretty significant increases in muscle gain and some noteworthy increases in strength. Again, nothing that like dedicated strength training program would do, but still better than doing nothing. Yeah. Pretty interesting topic. We've seen this come up a few times recently in the literature, so definitely something to consider if that's what you're looking for. This concludes the second episode of ExPhysCast. As always, all of the sources that we talked about today will be found in the show notes below. We hope you enjoyed our guest today. We enjoyed speaking with him. And there's really nothing new on the horizon other than episode 3, which is slotted for somewhere in the middle of May, probably the 15th. So be on the lookout for that. In the meantime, keep learning, keep living, and we'll see you next time.